Hi there, everyone. Thank you for joining us tonight. We are going to give it just a couple of minutes so that we can let people join, and then we will get started with the Q&A. We're going to ask that anybody who has a question go ahead and put it into the Q&A so that we can make sure that we are not having a redundancy of the same question over and over again. And we are going to start by going over some of the questions that were asked during our previous sessions. And I also want to let everyone know that we want to respect everybody's privacy as much as possible. So please, if you are asking a question, do not give any identifying information regarding a particular patient or your own specific child. That way, this recording can be used publicly without concern for any sort of privacy violations for our participants. Okay, so Dr. Papolos, welcome. Thank you for being with us again to talk about this groundbreaking diagnosis of fear of harm, FOH, TSDD. As the knowledge evolves, so does the name. And I want to start, as I said, with some of the questions that came in during our previous two sessions. And the first question that really comes up over and over again is about differentiating this diagnosis amongst all the other alphabet soup that we've talked about with the other diagnoses that kids often get in childhood, including ADHD, DMDD, borderline personality disorder, OCD. You know, how people want to know, how do we reconcile the fact that there's such an overlap in symptoms?
Well, I'm not sure how we reconcile it, but I think, I mean, it's perhaps most telling to say, I mean, my practice is kind of like a tertiary referral center. So I see people typically who've been treated with had been diagnosed with multiple conditions and treated with a variety of different medications, some of which have typically made the condition worse. So it's important to be able to make the diagnosis instead of something else. But there is a lot of overlap of symptoms. I mean, for example, forgetting about the specificity of the fear of harm diagnosis, there's a overlap of about 90% when you look at the DSM category for ADHD with bipolar disorder and the way it presents in childhood. So in essence, unless you rule out bipolar disorder, in my mind, you can't diagnose ADHD, certainly not safely. And there's a significant overlap with OCD symptoms. I mean, the fear of harm name basically comes from the trait, which is a heritable trait that we found amongst this subgroup of individuals who were either diagnosed with bipolar disorder or came from very enriched families with that condition. So we selectively looked at those cases. We weren't looking at individuals who were diagnosed with these other conditions, which would be a good study to do, because it's possible that this trait and the symptoms that go with it may occur in other conditions. I think the way I view it is that, as many people know, the categorical diagnoses that have been developed in the DSM, which go back to the DSM-3, I happened to be a resident at Columbia at the time that it was being promulgated, and I saw basically how the sausage was packed, and it was really much of a consensus and more of a political discussion between vying groups, and So it started that way, and there hasn't really been much evidence-based research to justify any of these conditions. So we've been functioning with a classification system that's pretty porous, and where there's a lot of overlapping boundaries between conditions. So when you start with that premise, it becomes very easy to understand why a condition that's been now identified that has a clear biological marker and also has heritable traits that define the symptoms, but overlaps with all of these other categories that have been developed, let's say. It's very easy to see why there would be a lot of overlap. And these are all of the conditions that most of the kids that I see, not just kids, but adults that come into my practice, have been diagnosed with previously. And let's put it this way, the diagnosis doesn't persist after they're given appropriate treatment for the condition.
When you said something that I want to circle back to, this FOH diagnosis is really a huge paradigm shift, isn't it? In that there's a biological marker, and the presence of that marker can either prove or disprove the presence of the disorder in a way that is not true for these other diagnoses that are in the DSM that kids are getting diagnosed with.
The presence, so far as we know, the presence, I would say, of the thermoregulatory systems, which are pretty clear, although there's a spectrum, but easily identifiable if you were to ask 9 questions on the questionnaire that we've developed. And they have these other features, these behavioral features, many of which are heritable. Meaning there's a genetic basis for them. Yes, I would say it is a paradigm shift that could lead to much greater understanding about psychiatric conditions in general and the significant effects of thermoregulatory problems on behavioral symptoms.
A lot of people are curious about that first criteria in the proposed diagnostic criteria for FOH, which states the presence of bipolar disorder, that has already been or can be diagnosed. And a lot of people want to know if the FOH characteristics and diagnosis can exist independently of a bipolar diagnosis or not.
Well, it's the $64,000 question. I mean, as I said previously, we were originally going about trying to identify homogeneous subtypes of early onset bipolar disorder to do a genetic study. And that was our aim at the time. So we only looked at, individuals who'd been diagnosed with the condition, those that came from enriched families and that met the criteria that we had established at that time, which evolved as with more research. So we didn't look at groups of individuals who'd been given a DSM diagnosis of OCD or any other condition from the DSM. So it's again, the subject that, would be interesting to look at in various specialty clinics, but from our point of view, we do not see in our sample individuals with, we see they have bipolar disorder, and then they have these other very specific features. So that's really as much as I can say about it.
So, Dr. Papolos, when people hear the words heritable, when they hear biomarker, one of the questions that comes up often is, so is there a test for this? How do you answer that?
Yeah. Well, we have an inkling of a test, but there's just not enough, funding and research that's gone on to pursue that. It looks like it'll just have to be a clinical diagnosis based on the thermoregulatory symptoms, which are very clear from a very early age, and they have a profound effect on the development of the condition. So, once you understand the symptoms and how to elicit them, and I mean the sort of preliminary screener, the Child Bipolar Questionnaire, which is available to all clinicians through our website, and it is a very good screening tool and can identify this syndrome preliminarily. And then, by looking more deeply into the specific thermoregulatory symptoms, and that's a matter of asking 9 questions. You can pretty much nail down the diagnosis. I mean, it's not rocket science. It's pretty simple to identify, unlike many other conditions in the DSM.
And you mentioned the Child Bipolar Questionnaire, and earlier you mentioned sort of 9 questions that can be asked around thermoregulatory disturbance. And I just wanted to point out for our audience that those 9 questions and access to the Child Bipolar Questionnaire can be found on the JBRF website, where Dr. Papolos, you have created a page that walks clinicians through, these are the things you want to be looking for in order to do that diagnosing.
Yes, that's true. Thank you for mentioning that.
Yeah. So, Dr. Papolos, there's a lot of questions about the fact that when we talk about FOH, we're talking about children, and that and the questions sort of that come around that have a couple of different directions that they take. One is the question of without treatment, will kids just grow out of this? Is this a developmental stage or phase of some kind that they will go through puberty and reach early adulthood and these symptoms will dissipate naturally? The other question that they ask about age is whether or not, if a child was undiagnosed as a child and grows to adulthood and still has symptoms that are untreated, can they then be diagnosed as an adult? Or does the diagnosis have to happen during childhood? What do you think about those 2 questions?
Well, I have a lot of thoughts about those. Those are very good questions, actually. From the initial question about the longitudinal picture and whether these early onset of symptoms progress to into adolescence, but then somehow disappear. We don't have real longitudinal studies. We have cross-sectional views of different age groups and, in a sense, how the condition may present in adulthood and how it may be different. I think it may be helpful to talk about the fact that this is a condition that develops over time. It evolves, and if it's not treated, in my experience, it gets worse. It's kind of it's in some ways it's a malignant condition if you diagnose it early on, and we can do that as early as 6 years old, sometimes earlier, largely because of the thermoregulatory symptoms that beget the sleep disorders and the arousal disorders of sleep that produce nightmares and night terrors that go on to essentially establish a particular behavioral repertoire of symptoms that evolves over time as that child encounters the environment and in a very fearful way. And I think understanding how the condition develops, which you can only do if you've seen these cross sections of individuals over time, is the most important aspect of understanding how it presents and how it develops. But in terms of answering that specific question, you really would need to follow, several hundred cases over a long period of time, and and see how what evolves. And so it really would, not be very objective of me to give an answer to that. And the other question had to do with do adults present with this condition? Was that?
Yes.
Yeah. So adults do present with the condition, and obviously we can answer why that is because they don't get diagnosed. I mean, by our estimates, based on and when we originally did these studies, these concordance studies, which led to the identifying this heritable phenomena. And as I said, we looked primarily at bipolar disorder. We were, we see these symptoms progress over time. If they're not treated, at least in my experience, they progress and endure and evolve in very distinct ways. Let me give you an example. A lot of the behaviors that develop out of this fearfulness that these children carry around with them, basically lead to avoidance behaviors of all kinds. Early on in school, often school phobias are very common, and they emerge in different ways at different times of life. So again, I mean, the idea is that it's an evolving condition. If it's not diagnosed in childhood, then it does persist and it evolves. But what evolves is essentially more of a rigidity around these symptoms of fear of harm symptoms, aversion, avoidance behaviors, and aggressive behaviors in impulsive, aggressive behaviors in response to the perception of threat. So one can imagine what that might look like in adolescence or mid-adolescence. Then it's very likely that, I mean, we wanted to do studies for a long time looking at the juvenile justice system to see how many children that have FOH or get incarcerated, and because that's would be a natural trajectory for many of these children who are untreated. There are adults who don't necessarily go down that path, who have bipolar disorder that have this condition as well. And anybody who has bipolar disorder that has a thermoregulatory deficit, as I said, and that's pretty easily identifiable, should be a suspect for having the condition. And then you have to go back and get the childhood history, and you can confirm it that way clinically.
So I think anybody who understands the proposed diagnostic criteria can see how not providing treatment for this disorder would be fairly devastating and catastrophic. Can you speak to what happens when kids get an inaccurate diagnosis and they're started on medications that may actually run counter to how it's supposed to be treated? What happens when SSRIs or stimulant medications are used?
Well, we know that SSRIs and pretty much all antidepressant medications, all classical antidepressant medication in bipolar disorder are really not indicated. And that's been shown a number of times by very large-scale studies that they're not helpful, and that there's a tendency to cause cycling and more extreme hypomanic behaviors and aggression. And I would say that holds true for children that I see and the history of that I get when I see them, which is usually after 5, 6, 7 trials, usually 4 or 5 of them with different kinds of stimulants, which gets, because the condition is often diagnosed as, extreme ADHD often, and then if one if one amphetamine doesn't work, then you try another amphetamine, and that goes on for often a year or two. And then, often then another set of symptoms, the OCD symptoms or the significant separation anxiety becomes more, is something that's viewed as more prominent. And so, the SSRIs come into play, and and you're often running, unfortunately, down a very bad path.
So would you say that from a diagnostic standpoint, a patient who comes in having had an adverse or atypical response to an SSRI and or to a stimulant would be a red flag that maybe you were potentially looking at a bipolar or FOH diagnosis instead?
Well, it used to be back in the olden days that that was a way that clinicians would make the diagnosis. They weren't sure whether it was bipolar disorder or not, and they'd give a stimulant, and they'd see what would happen, and then they would be able to make the diagnosis. I wouldn't advise doing that anymore, but just to give you an example of at least what was done in the past. Unfortunately, that doesn't seem to make a difference these days. It's just the wrong medication.
So we have another question about presentation of FOH and whether or not, in your experience, there's a difference in how symptoms present in males versus females.
Yeah. Again, I think that would really require a study that would look at the differences in gender so I don't want to make any blanket statements about that because I don't. Overall, I would say they're not necessarily any differences, but I really can't say for sure.
Okay. So back to the topic of medication. You said that ketamine was first identified as a treatment for the FOH symptoms because your study indicated that you were looking for something that would reduce fear sensitization and body temperature. Can you specify what fear sensitization means in that context?
Sure. So there's an animal model that that has been used in terms of trying out anti-epileptic drugs that involves kindling the amygdala with electrical shocks and essentially stimulating the animal to become fearful and often aggressive, and then they give the anticonvulsant that they happen to be testing out, usually before the application of the shock, and to see whether it reduces it, and that's within the animal model literature. That's what fear sensitization means. The meaning that we give it is essentially that it's very much like a recurrent traumatic experience that leads to fear and fearful responses to whatever the stimulus happens to be. Excuse me.
Is that where
And
the term auto-traumatization came from?
yes, exactly. And so that generalizes over time. And so what are the things that happen, for example, with PTSD? You have these traumas, and they can be recurrent or complex traumas that are triggering essentially a stronger response, typically in the limbic system, in that part of the brain that regulates the fear response. And then, to the extent that you have the recurrent trauma, it becomes generalized in terms of the way you're actually viewing the environment and what presents itself to you on every day during the day. And so you start to scan and plan the environment. So there's literally a triggering of behavior where you're looking for things that may be coming after you, and your focus of attention is fixed on those things. And that's what really seems to be happening with these children as it evolves. Now, in terms of auto traumatization, that was a word that Marty Teicher came up with to describe what we were seeing, in that one of the major symptoms are arousal disorders of sleep that begin very early on, typically with these children, and there's a panoply of symptoms that they have that involve sleep. But nightmares and night terrors are perhaps the most common, and they are really, when you hear stories about what kinds of the content is, I mean, it's all about pursuit and abandonment, and it's recurrent. It can be nightly for months at a time, and often it's just brushed off as normal developmental, phenomena that occurs in childhood. But for these kids, this is not normal developmental. And we think what happens is that, and I'm not going to get into all the details, but this is where the thermoregulatory problem, contributes, because temperature regulation is extremely important in the transition from REM to non-REM sleep, and vice versa. And it's in those transitions that when they're unstable transitions, that you get these arousal disorders of sleep, and you wake up in the middle of REM, and largely because your brain is too hot and you're getting a signal that your brain's on fire, it's time to get up. And I mean, this is really gets into the realm of real speculation now, but we believe that signal, is actually triggers this imagery that leads them to, partially come out of REM state, and so therefore they're in a higher level of consciousness than they were during, even during REM, and that those memories really get recorded as if they were real. And since they're so recurrent, you have a recurrent traumatic events that would be described as auto-traumatization, and essentially a form of PTSD. And that's what we see in terms of the behavior in these children that can develop.
A lot of people, when they talk about medications, have questions about antipsychotic medications. And you touched on these in our last session 2 weeks ago. And in the intervening time, there was actually an article in the New York Times about the effect that antipsychotic medications have on body temperature. And so I would assume that when you're diagnosing and treating FOH, that is something that a physician prescriber would have to be very careful about using if they suspect a thermoregulatory issue. Do you have thoughts on that?
Yes, I do. I mean, dopamine is a very, very important, and so is serotonin, neurotransmitter in terms of the regulation of body temperature, and so therefore any drugs that are either amplifying or inhibiting those neurotransmitters can have an effect on thermoregulation. Sometimes you don't have a choice because, even sometimes, I mean, some of these children really have very severe bipolar disorder, and, they may not even respond to mood stabilizers, and you have to resort to using a major tranquilizer. And Just that you have to do it cautiously and realize that there are, however, it has been shown in animal studies that both Seroquel and risperidone actually can lower core temperature. So there's only one study that was done, but it was a very good study that was done by William Blessing a number of years ago. And so that for me is a justification. Not that anybody studied it in humans or primates. So it's sort of maybe, yeah.
So we had a question about the order in which medications are introduced to treat FOH. And in our last session, you talked about the fact that the mood stabilization needed to come first, and that once there was a measure of mood stabilization, then the ketamine is introduced to address the temperature and fear related and triggered symptoms. Can you talk a little bit more about why it's important to have that mood stabilization first before ketamine is introduced?
Yeah, and this was basically something we learned clinically over time, that if you weren't really certain that the individual was not cycling anymore, essentially not having any mood cycles, and that the symptoms were primarily that were left were these symptoms that could be attributable to the fear of harm. Ketamine at escalating doses could induce hypomanic symptoms, and which you obviously don't want to do. So usually we wait, if we for at least 3 weeks until we see stability, mood stability, and before we entertain a trial of ketamine.
In the last presentation, you talked about the delivery mechanism for ketamine being either intranasal or sublingual. A lot of folks now are aware of the fact that there are ketamine clinics that do infusions. Is there a reason why ketamine IV infusions are not the preferred method for administering ketamine in the FOH diagnosis?
Well, is there a reason? It's never been studied really. I mean, that's one thing. I have a number of adult patients who periodically will have what they refer to as boosters, of IV ketamine. This is usually if the intranasal or sublingual ketamine, you haven't been able to achieve a dose that has a complete, effect. But is there any reason? I mean, not that I can think of, other than what's been studied is treatment-resistant depression, and what's been given an indication for S-ketamine, which is Johnson and Johnson's developed brand, and that is extremely expensive, and also requires going to the clinician's office and sitting for 2 hours after you receive the ketamine. For me, that would be a reason that it would be difficult to administer to these children, particularly in adolescents, who would not be able to do that, a few times a week, and it would be vastly costly for their parents.
So you mentioned Spravato, esketamine, and aside from the exorbitant cost, and aside from the impracticality of having to be in the physician's office for every administration, from a molecular level, or from the level of the medication itself, is there an advantage to generic ketamine over something that has been branded?
Well, I think that's what the belief was that Johnson and Johnson went into their clinical trials with. I mean, I wouldn't want to be cynical about a pharmaceutical company, but the ketamine is extremely effective, and it works very well both for forms of depression and particularly for acute suicidal ideation. And so they realized that this was a blockbuster, but the ketamine that was uh, being used by many different um, physicians in various quarters is racemic, and that was the one that was developed about 40 years ago and is off patent. So it costs pennies, basically. So there were some studies that have been done, somewhat before Johnson and Johnson came up with this plan to essentially. So ketamine's a stereoisomer. That means that it has essentially the molecules are mirror images of each other. There's the right-sided and the left-sided molecule, and racemic means there's a 50-50 pairing of those. And So there was some studies that had been done by the U.S. Army, I believe, looking at ketamine as an acute analgesic in wartime, and they had come up, and it was a kind of a marginal study, that the S form had more of a potent effect than the racemic in that context. Um, and So that I don't know. I mean, I don't know what was in their minds, but that I think may have been the reason why they may have chosen that as the way to go to develop a marketable, branded, expensive drug. Um, uh, During the middle of their trials, a number of studies came out, animal studies that were done looking at animal models of depression, and they did not find that. In fact, they found, I think, in several studies that the racemic or the R form was a bit more effective. So there's no reason in my mind to think that that would be a, a better blend to give. And the racemic, as I said, doesn't cost much. It's easily compounded in compounding pharmacies, and they do it for many, many other things. I mean, so it's not. It's used in a variety of settings, chronic pain, and it's used in burn units to give in place of opiates when they change the burn dressing, and it's used frequently in emergency rooms as a tranquilizer, analgesic, even in young children who are getting sutures, basically. So,
So, so some folks know of ketamine as anesthesia, and that it's often used in anesthesia cocktails during surgical procedures. And they want to know, is the dosing that's given to treat fear of harm a sub-anesthetic level? Are the children, when they take it, are they having that same experience as though it were being given by an anesthesiologist, or is it different?
uh, no, it's different. I mean, you can basically give a graded dose intranasally, which I find the best way of establishing what a therapeutic dose is, and to essentially customize it to the child and their side effects. And you can get to the point where you have what would be called an anesthesia, an emergence reaction, where you have dissociative symptoms. But that, in my experience, one, is not necessary to achieve. And also, in children, they develop very quickly tolerance to the side effects of the ketamine. So let me just say something about, yes, ketamine was, I mean, that's what it was. Its primary indication was in anesthesia. It was pretty much abandoned in the United States, but it's the most commonly used anesthetic around the world because it doesn't affect respiration. And so it's very safe. And, there are not a lot of anesthesiologists around the world, so except in developed countries. So it's used quite commonly.
oftentimes when people think about taking medication, they think about taking something every day or multiple times a day. But in the treatment protocol you laid out last time, the ketamine is administered every third day, every other day. I think you mentioned one patient who takes it once a week. What is the reasoning behind having it taken not every day, but over the course of a time interval of days in between administrations?
Well, ketamine does have some potential side effects. Perhaps the most significant that's been reported is um, urinary bladder, ulcerative cystitis, basically, of the bladder. And that's been reported primarily that I've seen in studies on recreational users who are using, up to 3 grams a day of the drug. But it's something to be concerned about. So delivering it, less than daily, and particularly it's not needed in my experience, that you can go, 48 to 36 hours, because even though this drug is very rapidly absorbed and metabolized within 36 hours, I think, it still has an effect that can be longer lasting, which implies that it's inducing gene expression, which we know it does, and that may be one of its principal methods of working.
So we are almost out of time for this first session. I wanted to ask one quick question. Someone had wanted a reminder about what year you first administered ketamine to a patient. How many years have you been doing this? How many years has this been studied?
So, well, let's see. The patient was 4.5. This was the first patient that was treated with ketamine and that had FOH, and she graduated from college this year. So, I think I'm not sure exactly how many years it's been, but that would date it.
Okay, so almost 20 years. And I think that's a wonderful, hopeful thing for us to end this session on. The idea that these devastating symptoms, when caught early, when intervention is provided, when needed, can really result in very positive long-term outcomes, because early intervention and treatment works. So we are going to pause now and be back in a half an hour for session 2 of our Q&A with Dr. Papolos. Thank you for being with us. Please feel free to send us additional questions if you have them. Otherwise, we will be back in 30 minutes to discuss some of the supplemental treatments that go along with treatment for FOH, not just the medicine. Thanks so much. We'll see you soon. Hi there, everyone. Welcome and thank you for being with us for this special live question and answer with Dr. Papolos, Research Director from the Juvenile Bipolar Research Foundation. We have collected the questions that were asked during the first 2 sessions of this presentation on the history of the identification of the FOH diagnosis, as well as the history of the identification of treatments and the new treatment protocols for FOH. So we're going to start with those questions that came in during the previous 2 sessions, but we are inviting our audience today to please feel free to put your questions into the Q&A as we go. We will integrate them into our conversation. I would hope, though, I would like to ask that folks not put any very personal information into the Q&A. Other attendees can see your questions, and we want to make sure that we are protecting the privacy of everyone who is here with us tonight. So please feel free to put your questions in, but perhaps make sure that they are anonymized so that no individual can be identified. So Dr. Papolos, welcome. Thank you so much for being with us tonight to continue this really important conversation on the FOH diagnosis and its treatment. One of the questions that we get very frequently and came up a number of times over the past few sessions is you talk about auto-traumatization and the degree to which the symptoms of bipolar and FOH can be traumatizing for the children who experience them. Can you talk about whether or not some sort of pre-existing external trauma is a requirement for the FOH diagnosis, or is it separate?
Mm-hmm. Well, it's a good question. So I think, as a colleague of mine once said, nobody gets through life unscathed, and we all have experiences, traumatic experiences of one kind or another. I mean, children usually have a shorter life history, so they have less trauma. The way we understand the degree of fearfulness that these children manifest in a multitude of ways in their behavior, in their responses to perceived threat, is that they have been auto-traumatized. And what do I mean by auto-traumatized? Well, so some of the early cardinal features of the condition have to do with the problem that we've identified with thermoregulation. And, one of the clear problems is they have difficulty dissipating heat throughout the day. And that's a very, very important function of our bodies, because we have to maintain like a temperature, a specific temperature within our blood, no less than a range of 2.5 to 3 degrees, and beyond that, we will basically cease to exist. So there's a whole signaling system to alert us about when things get too hot, basically, or too cold. But over the course of the day, we generate heat by muscle activity, brain activity. Our brains need 25% of the energy to get us moving around, and they generate, therefore, 25% of the heat that we generate as human beings. And that, obviously, if your body doesn't throw off the heat that's developing in the core in a gradual way throughout the day, then the core gets warmer and warmer and warmer. And and this affects behavior during the day, and also it affects what goes on during the sleep cycle. Temperature regulation is a key element of how we get to sleep, how we wake up in the morning, and how we transition between different stages of sleep. This is not something that's well recognized or well understood. Certainly, I didn't have much understanding of the importance of thermoregulation until we began to see these symptoms in these children. The auto-traumatization comes because of the temperature, circadian 24-hour temperature rhythm, and the sleep cycle are coupled. And if you basically are not dissipating heat well throughout the day, by the time you get to nighttime, well, you're pretty warm. And since temperature really determines your level of arousal, and it really is a major determinant of when you go to sleep. So we know this from the circadian literature, studies that were done, years ago, have shown that the outside skin temperature and the core temperature, the inside temperature, co-vary basically over the day and during the night. And there are several points where they become equal. And those points are when we go to sleep and when we wake up in the morning. And so the temperature difference between the core and the periphery or the skin temperature is a determinant of sleep onset, and it's a determinant like 8 hours later of getting up in the morning. And these children have significant problems with early insomnia, and they have significant problems with sleep inertia. Getting up in the morning is a huge task, as most parents know, and that's because they are essentially too cold and they can't get going usually until mid-morning. They're not really warmed up. And this is a factor that has to do with thermoregulation. Now, what does this have to do with auto-traumatization, you might ask? Well, so this variation of temperature occurs and is a signal not only for sleep onset and sleep offset, but also for transitions between different stages of sleep. So REM and non-REM, dream sleep and deep sleep, that the transitions between these different states of consciousness are regulated by brain temperature. And these children from the get-go have arousal disorders of sleep, well-known arousal disorders, the most prominent of which is nightmares and night terrors, often early on, starting, sometimes before they're able to talk. And these nightmares are the transition between one state and another, because it's temperature regulated. If your brain's too hot, you have an unstable transition periods between these stages. So they wake up often, at the beginning and the middle or the end of rapid eye movement sleep, which is mostly when we dream, and they aroused basically, and that's when they begin to experience these nightmares. And we believe they begin to experience them almost as they would if they were experiencing some traumatic event during the day. The nightmares, the themes of nightmares that these children have are, either pursuit, a monster, an alien is chasing them and wants to kill them, or they're being abandoned, by their parents and they're left alone. And these are very scary dreams. And for many of these children, they start early, they're recurrent, sometimes nightly, sometimes several times a week, sometimes weekly, and they come intermittently as time goes on. And as most psychologists know, intermittent reinforcement is stronger than something that happens very regularly. So what we believe happens is that they are really traumatized by the imagery that is created during these nightmares, and that begins to reflect itself in their behavior during the day. They're rapidly scanning the environment for threat. It's a basic survival response that is essentially overwrought because of this problem, this sleep disturbance that is begotten by a temperature disturbance.
So, Dr. Papolos, let me see if I understand what you're saying. Trauma and FOH are not necessarily mutually exclusive. They can both occur, but that in FOH, the trauma is not the result of an external experience. The trauma is a result of the FOH symptoms themselves.
That's our belief. Yes.
So we have a question here that's coming in around a lot of kids who have these mental health disorders. They have family members who have mental health disorders as well. When a family is talking to a provider, how important is it to provide information about the mental health disorders that immediate or extended family members may have been diagnosed with?
Well, I think it's very important, but of course, we are operating with a diagnostic system that is, shall we say, very fluid. The boundaries are very, very fluid. It's basically a classification system that's based on expert consensus, it's not evidence based. So, what appears in nature is not necessarily what appears in the DSM. So that's a caveat that I think is important to say, because even if you provide somebody with a diagnosis, you're not necessarily sure whether that's what it was. But I think the behaviors of individuals who have been, let's say, diagnosed with bipolar disorder, if there's clear number of first degree or second degree relatives, and the clinician that's taking a good family history will ask about the various behaviors of those individuals to try to at least ascertain whether the diagnosis was correct. I mean, I think that's important that information be provided. Certainly, in our experience, the early onset of bipolar disorder is often accompanied by family histories that are bilineal, that you see the condition and other spectrum conditions on both sides of the family.
So there's some questions that have been asked that I think maybe are not things that you have studied, but I just want to make sure that we address it. There's a question here regarding birth trauma playing a role. There's a question here about blood glucose levels and metabolism playing a role in sleep difficulties and temperature, and whether or not there's a higher incidence of bipolar FOH in children who have sleep apnea, since sleep apnea also impacts sleep stages. Would you like to respond to any of that?
Well, I can at least anecdotally address the sleep apnea. Everything else, I would say, it's a little bit vague, and I'm not quite. I mean, I know that I know of, there are no studies that would, look at that in an objective way. Sleep apnea is an interesting phenomena, and I've seen a lot of patients who get so diagnosed, and they legitimately have the symptoms of sleep apnea, and also some with narcolepsy. So sleep apnea. Let me just get down to the nitty-gritty anatomical aspects of it. So, what causes sleep apnea is that the vocal cords basically are this fibrous tissue that can get very taut if it's dehydrated, and it's looser if it's hydrated. And the tighter those cords are, the more difficult it is to essentially to breathe. And so this is where, and I'm not saying this is by any means all sleep apnea, but there is an anatomical basis that may relate to um, being dehydrated because you essentially, during the night, you dissipate a lot of heat, and there's a lot of you become very, very these kids particularly get, as I described before, become very, very hot. And so the dehydration that may make those vocal cords very, very tight can cause a form of sleep apnea. That's the only instances that I've seen where it resolves once you address the problems with thermoregulation. I mean, it's not a great example, but that's been my experience.
Um, a question that we get quite frequently and has come up a number of times over the last couple of sessions is the resistance within the community of providers that families experience around diagnosing bipolar in the first place. We hear about kids who have been diagnosed with mood disorder, NOS, ADHD, ODD, DMDD, OCD, and that after years of struggle for the families, they have this alphabet soup of diagnoses. And then they're treated usually with antipsychotics and ADHD medications, sometimes non-stimulant ones, but nonetheless. And so the question that families ask over and over again is, why is there such reluctance in the community of mental health care to diagnose bipolar disorder in children?
Well, it's certainly true. I mean, it's certainly something that I've seen many, many, many times over the years. And the most common statements that I've heard from particularly child psychiatrists, who often are the ones that are treating children, is that you can't diagnose bipolar disorder until adolescence, and even then, it doesn't occur very frequently. So there are a number of reasons for this. The DSM does not have a diagnostic category for childhood onset bipolar disorder. So, and remembering that these are consensus diagnoses, so the consensus looked basically at the way this condition presents in adulthood, and that's what's in the DSM. And because one of the things that's required to make the diagnosis is a specific number of days that you must be hypomanic or manic to be able to qualify for the diagnosis. Now, even though the literature is chock full of good research that's shown that children with bipolar disorder have very rapid cycles, often ultra rapid cycles within the day, this somehow is not penetrated I guess the educational bastions. And so the teaching has basically been this way for years. And in my mind, it's pretty much mythology. It doesn't really pertain to how the condition presents in early childhood. This is another big problem with the DSM. It doesn't take into account anything about development, that things change over time. I mean, our brains are not fully functional until sometime around the age of 23. So there are a lot of changes that are going on, and the way one presents various symptoms changes. And certainly there are ultra rapid cyclers that are adults, but it's extremely rare. So, I think, but for children, these cycles are within the day. And so they can't meet the current criteria because essentially they're not adults, unfortunately. I mean, it really isn't a laughing matter. It can really, really causes havoc with many, 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 many families across the country. This is not, it's not specific for one area. It's a national phenomenon.
So one question that is, excuse me, adjacent to that, that comes from families as well as from some providers, is that they've been told that DMDD is the bipolar diagnosis for childhood, and that's not that's not the case, is it?
I'm sorry, you kind of cut out there for a minute, Elizabeth.
Um,
What was
so the
again?
question is, folks have been told that the diagnosis for bipolar disorder in childhood is actually DMDD. That if you want to diagnose a child with bipolar disorder, you diagnose them with DMDD. But that's not correct. Can you explain why that is not correct?
Well, I think you have to go into the history of how that diagnosis emerged, and so people understand better. Because again, we're talking about consensus, right? And consensus amongst the child psychiatry community, who basically uh, developed this diagnosis. Um, so back in around the year 2000 to 2005, clinicians began to diagnose bipolar disorder a, a lot. There was a noticeable increase in the diagnosis of early onset bipolar disorder, and there were probably a number of reasons that happened. There was a lot of research during that period of time. There were books that emerged that were describing the syndrome, and a lot of, particularly, I think, psychologists picked up on it, and it became something of a it became more commonly diagnosed, and the percentage of the diagnosis was more akin to the percentage of the prevalence in adulthood. um, uh, Before that, as I said, and now, since that diagnosis was inserted into the DSM, there was a major drop off in the diagnoses. So, in a lot of ways, the way I view it is it was a very conscious decision that by the people that essentially are the consensus group that said we're overdiagnosing childhood bipolar disorder. We have to somehow find a way of preventing this from happening. And there were some studies that went on at the NIMH, all very small studies, and none of them were treatment studies, by the way, that came up with this particular diagnosis. And this, came into ascendancy within that group that decides on these things. And this was back, several years before the DSM-5 emerged, and they essentially christened this new diagnosis. Now, subsequently, the studies that have been done by, I think it was the World Health Organization, found that there really was no difference between what they were calling, DMDD and oppositional defiant disorder, and that you couldn't separate the two. And essentially, they've decided that it's sort of a bogus diagnosis and not something that really deserves to be classified. But I think it served its purpose, because it did discourage and continues to discourage clinicians, along with the fact that there is no childhood onset bipolar diagnosis, that from diagnosing the condition. Those are the factors that I would point to. So it's complex. Sorry, I can't hear you.
Apologies. So in the diagnostic criteria in the DSM for DMDD, disruptive mood dysregulation disorder. One of the notations is it explicitly states that the diagnosis of DMDD cannot be applied if the child has had a manic episode. And I'm wondering if you think that that has not been a sufficient deterrent to the use of the DMDD diagnosis, precisely because clinicians have difficulty recognizing what manic symptoms are in children, since they don't always match adult presentation.
Yeah, that's exactly right. So they don't have mania for a week. It's within the day, typically. It can be longer, but it's most often, in my experience, within the day that they have this very rapid cycling. So, yeah, it's sure it's kind of a caveat, but since they don't present as adults, I guess you diagnose them with DMDD.
There's a question that's come in through the Q&A where someone is asking, can FOH start in adulthood? Can it be created or triggered by some bad, scary, traumatic experiences that the person has had? Is that possible for FOH to not develop until later in life?
Oh, it's a good question. I mean, I think it would be diagnosed as PTSD at that stage of life. Um, I think that we're talking about is a very early developmental disorder that evolves over time as a result of a very clear biological problem that has to do with the ability of the body to dissipate heat, and that it produces behavioral symptoms that are significant, and that if it's not treated, it evolves and becomes more serious and severe. I mean, that's in a nutshell, that's the way I would look at it. So the recurrent experience of these nightmares and the fearfulness and separation anxiety and the rituals that develop around going to sleep and the avoidance behaviors that also develop are essentially cultivated over time. So in terms of what I'm talking about, it really would probably not develop, and it couldn't develop in that way in adulthood, just because of the time of life.
So we have questions about the possible range of intensity of symptoms. Is it possible to think of FOH symptoms as presenting on some sort of scale or spectrum where there's a more intense versions versus less intense versions? Some parents will say, well, my child definitely has, the nightmares, but they are not particularly physically aggressive. They are just verbally aggressive. Are we to think of that as a sort of spectrum of intensity that is possible, or would we look at that and say, well, no, if it's not that intense, then it's not FOH?
Well, I think with like anything else in nature, there's a spectrum, and it's dependent. I mean, how it presents, I think, is dependent on a lot of environmental variables. It's nature and nurture. I think the fear sensitization, which drives the behavior and the development of these behaviors, is something that is essentially kindled in early childhood, and that's one of the major differences, I would say.
So would the symptoms appear different in adulthood, or would we be looking at the same symptom presentation?
Well, no, I think they do. They're modified. I mean, significantly, as I mentioned before. The frontal lobe doesn't fully develop until you're, somewhere around your 23, 22 years old. And it's your frontal lobe that allows you to inhibit very strong impulses. So I think there's um, a much greater likelihood that the degree of aggressive behavior is much more limited because there's more control over those behaviors. I think the fearfulness really turns more into avoidant behavior, but this whole process that develops of planning and scanning during the day, where you're looking for things around you that could potentially harm you, and that sentinel is on all the time. So I think more than anything else, it may turn into fearful ruminations, anxious ruminations about things that are going on that are misperceived.
So there's a question here about that adults don't typically rapid cycle. I'm not sure, to the person who wrote that, I'm not sure that's what Dr. Papolos said. I think what he said was that children tend to rapid cycle throughout the day. Do adults rapid cycle as well? And if not, would one expect that as children age, their symptom presentation would morph and look more like the adult symptoms?
Well, one, it would depend on how early they get treatment and how well they respond. Um, so, and I'll sort of divert here and say that, well, let me say about that. I mean, there are ultra rapid cycling adults. Nobody's ever looked at a group of ultra rapid cycling adults to see if they had early histories that would be compatible with the FOH diagnosis. So we don't know, or whether they have thermoregulatory problems. We don't really know, except for one study that hasn't been published as yet, what percentage of adults with bipolar disorder have thermoregulatory problems. In that small study that was done at McLean Hospital, it was around 30%, which makes perfect sense from my point of view. So there are adults who have thermoregulatory problems. Now, whether they started in childhood and whether they had the symptoms that we've identified as FOH, we don't know. That's not something that's been studied.
There's an interesting question here about sort of differences in the diagnostic process from the US to other countries. Like in the UK, they have the diagnosis of pathological demand avoidance, and that many of the characteristics of FOH in the UK would be perhaps diagnosed as, this person is speculating, as a dysregulated neurotype of autism. And this person is asking about whether or not you can speak to those similarities. And I'll say, I think that you did address this quite nicely when you were talking about the porous nature of those DSM diagnoses. But is there anything you'd like to add to that?
Well, I can say that many of the children that I have evaluated that come to me have come after they've received a multitude of diagnoses, and a good percentage of them have been diagnosed with autism spectrum disorders. I'm not altogether sure what that means and why that is, but there is a certain level of rigidity that develops when you are essentially operating pretty much constantly under threat and feeling and fearful for your own survival, and that leads to developing, routines and rituals and needing to be in control and avoiding, things, many experiences in the environment. So I think there is a behavioral overlap with many of the symptoms. And if you don't have adult mania, that's one of the diagnoses that you can give.
So there's a question that I think is important to address. The question is, will children who have FOH or any type of bipolar disorder definitely continue to have bipolar disorder as adults, or will they grow out of or outgrow the disorder?
Again, there's no longitudinal study that we can look at that would be able to answer that question with any objectivity. I mean, it's just would be my anecdotal experience, and I, even though I treat a large population of these children, I don't. There aren't enough that have reached into adulthood for me to really be able to comment on that. It's I think if you this is what I would say, and this is again with the caveat of take it with a grain of salt. I think if there's a really strong family history of bipolar disorder, and into adulthood, then I think you can probably bet that if it presents in early childhood, it's the form fruste of the condition, and there's a vulnerability to cycle that continues throughout life.
Dr. Papolos, do you think it is fair to say that generally speaking, without treatment, mental illness it is progressive?
Well, that's a broad term, mental illness. I mean, I'm not sure what to say. It depends on what we're talking about. Um, so I think the condition that we're talking about here is definitely progressive. I mean, I think one of the ways I think about it is that when you're fixed in fear and you're really feel easily threatened and you're misperceiving things because you have this fear sensitization, you develop a repertoire of behavior that is pretty limited when you think about it. And it really is much about dominance and submission. You want to be in control of the situation all the time so that you have control over the threat that may be coming, and that is the quintessential aspect, I think, of the behavior that develops over time.
So we have a question that's moving us sort of towards non-medicinal treatments. And so to the person who asked about managing the fear and aggressive reactivity with medications, I want to direct you back to the recording of our last session where Dr. Papolos explained all of the medicinal interventions that are used to treat FOH and the medicines that are specifically used to treat the fear sensitization and the body temperature dysregulation. And now move to the second part of the question, which is about DBT versus ABA therapies. Do you have thoughts on what types of psychotherapeutic interventions are going to be most effective or most useful for children and teens who are living with this disorder?
Well, let's talk about I think children and teens. The most effective treatments that actually there are randomized controlled studies that have been done that have examined several treatments, but primarily forms of family psychoeducational treatment have been the ones that have been reported on and that are really effective and serve as very, very good adjunctive treatments to the condition. And that really has to do with, educating the family, with the child, And there are, a number of different protocols that are available in the literature that have done various ways of doing that. So I would, and David Miklowitz is one of the major, people in the field that moved that forward, and has done a number of these randomized controlled studies. And that's really the gold standard for determining whether a treatment is effective or not. And then DBT, I think, is very helpful in terms of helping individuals, maybe more older in adolescence, to control impulses. I think it can be a very effective adjunctive treatment. I don't, there's nothing that I know of that's been studied that in terms of psychotherapy, and that's unfortunate because I think, with these children and adolescents, it really takes a village. There ought to be a number of providers that are communicating with each other, not in their own individual silos, which is unfortunately the way the treatment delivery system is set up in this country. There are different parts of it. There's the treatment, the medical treatment, the somatic therapies that need to be applied. There's this need, really. I mean, these kids are in school and they're school phobic, and they're school phobic because they're not typically accommodated because nobody understands really what's going on. And, educational consultants to help parents guide them in how to change the IEPs is very, very important, I think, as an adjunctive measure. Occupational therapy has a real place, I think, because there are sensory issues that these children have, and that's a whole area that I think would there a lot of could bear fruit. Studies on how these children are within within that setting. But what's available and what's been used is really very, very little. There's a real paucity of any kind of studies on this.
And Dr. Papolos, you mentioned Dr. Miklowitz, and I want to just let our audience know Dr. Miklowitz has a book called The Bipolar Survival Guide, which does have a chapter in it specifically about children and pediatric onset. And many families in our community find that book to be a tremendous resource. Additionally, I would say the number one book that is the greatest resource for members of our community who are families and parents and caregivers is Dr. Papolos's book, The Bipolar Child, which you can get on Amazon. But I highly recommend it. It is on my bookshelf and is always there for reference. A lot of questions about bipolar specifically, not necessarily FOH, can be found in the treasure trove of that book. So, Dr. Papolos, let's talk for a little bit before we end about some additional non-medication-based treatments for FOH. Some parents may be reluctant to use medications. Others find that medications are not sufficient to completely address the symptoms that they have concerns about, specifically the temperature-driven ones. Can you talk a bit about the cooling strategies and the circadian rhythm interventions that you recommend to your patients when treating FOH?
Yes, I could comment on that. So, I mean, just thinking common sense wise, if you're, all of us are coolest in the morning because we've been lying down and we haven't been generating heat much during the night. In fact, we've primarily been dissipating heat. It's been coming out of the core and goes out into as insensible loss. um, and so, we are cold, and if you don't regulate temperature very well, you may be very, very cold in the morning, which we talked about as a symptom of sleep inertia. But very quickly, you're out of bed, you're moving, muscles are moving and generating a lot of heat, and that heat accumulates over the course of the day, gets sequestered when it's not dissipated well. And by the nighttime, and this is a worthwhile saying, usually sometime around 4 or 5 o'clock in the afternoon, or I mean, classically with this condition, that's when many of the aggressive behaviors begin to occur, and a lot of fighting is occurring, and that's largely due to this overheating of the core, and leading to that kind of loss of impulse control, and misperception of threat and aggressive behavior. Um, so and then we talked about what happens into the night. It's very difficult to get to sleep. And you can get to sleep only when the core and the skin temperature cross over, basically, where they're equal, and so that becomes a problem with difficulty getting to sleep. So what to do? Well, we talked about in one of the, the workshops some of the medicinal ways in which you can help the body to dissipate heat, but very simply, cooling the core, ventilating the skin, are and submerging the body into the trunk, particularly into a body of water like a bathtub or a swimming pool. I mean, this is perhaps the most effective way that the body has of dissipating heat. And so that's one of the recommendations: sometime half an hour before sleep, a lukewarm bath for 15 minutes, and you're helping the body to get rid of heat before sleep. But proactively using various cooling measures during the day, and this was somewhat arbitrary, but we said from 12 noon on, you cool the gut, ventilate the body, and use what are called these ice necklaces that go around the neck and actually cool some of the blood that's going into the brain. So drinking ice water, I should say, water with ice in it, putting a fan on to ventilate the body, and cooling blood vessels going into the brain, all at the same time for about 10 or 15 minutes every 2 hours through the evening hours. Is the intervention that we recommend, for regulating the body temperature. So those are the major points I guess I should make.
And in your presentation last time on the treatment protocol, you really stressed that it's a combination of medications introduced at the right times in the right order, and these cooling strategies and sleep regulation techniques that really combine to make for the most effective possible treatment.
Yes.
Well, we are out of time for tonight. I would like to thank everyone for being here with us. And Dr. Papolos, I would like to extend a special appreciation to you for being with us for these 3 independent sessions on the identification of the FOH diagnosis, the identification of its treatments, and making yourself available to answer all of these questions. It is always a pleasure to collaborate with you and with the Juvenile Bipolar Research Foundation. We are grateful for for the research that you do and the insight that it brings to the many families who need that information in order to be able to get the treatment they need for their children. So thank you for what you
Well,
do.
thank you. It's been my pleasure.
And everyone, please take a look at our website. We do these clinical seminars and webinars every month. We have new ones coming up in July on the 3rd and 4th Wednesday. We also have a very special book club session happening on Thursday, July 18th, where we are hosting Dr. Georgia Ede, author of Change Your Diet, Change Your Mind. And she's going to be with our book club participants to talk about her book, to answer questions in an intimate setting. So please go to our website, cmhrc.org, to check out all of those offerings. And if you're interested in getting more information on the research that Dr. Papolos and his team have done, please head to their website at www.jbrf.org. Thank you so much for being with us tonight, and we look forward to seeing you again soon. Thanks, everyone. Good night.
Right.